Fantastic. And now we go to this live panel, and we hope to bring in Dr. Lawton and Dr. O'Gara via satellite into the room. Hopefully you can do that for us as we start this with our panelists live here, Dr. Tamis, Dr. Patenl, and Dr. Puskas. Manesh, let me start with you. We saw the evidence put in front of us over the last year from both Dr. Lawton and Dr. Tamis-Holland. What's your expectation for the revascularization guidelines? In what way do you think we will progress moving forward? What's your predictions?
So I'll just start by saying I haven't seen them or reviewed them. So these are true predictions. No new information. Some may wonder.
Oh, I'm glad about that. Yeah. So if you hadn't seen them, then
yeah, I haven't seen them. But my predictions are the data would make us think over the last actually since the guidelines haven't been updated since 2011 and 2021, a 10-year span, 5-year span for PCI stents. And so I guess the big messages are, as you saw, I think first, much more coronary physiology, both non-invasively and invasively with coronary imaging to direct care for PCI in the ACS and shock setting. There's now data to revascularize completely in the non-shock setting, not revascularize in the shock setting as much. And obviously in the stable setting, the data both with the ischemia trial and the data we've seen now would make us believe that we are going to continue to focus on putting the heart team and the patient in the middle of a discussion, but CABG certainly is preferred in stable patients with multivessel disease, left main, and diabetes, high complexity, a low EF.
Great. I see Dr. O'Gara. Welcome, Dr. O'Gara. We wish you were here in person, and we're very, very grateful to you. We know that you have you've made time for this live discussion. Unfortunately, Dr. Lawton had to go to the OR at 10:30, and we're a couple of minutes behind. So let's begin the discussion. As the head of the task force, Dr. O'Gara, and as a clinician, what are you hoping to expect from the guidelines? And what do you want to tell the audience here and we have over 1,000 participants in the virtual platform. And I'm really excited. So you're the head of the task force, and tell us what you're expecting. Dr. Puskas, if you do not have a conflict, and you are conflicted, we're all conflicted, surgeons, interventionalists, but you have not reviewed the guidelines, or have you? Because I don't want you to comment on what you're expecting if you have.
I had the privilege of participating in the 2011 guidelines, and I think I was so outspoken I wasn't invited back. So the short answer is that no, I've not seen the updated guidelines. I think that the keys are that we should truly keep the patient center and use the heart team approach. I view this very much as a partnership. In the big picture, I think that cardiologists should be working and should be unabashed in manipulating your surgical colleagues to perform better coronary surgery.
Yeah, I think the data on the total arterial revascularization is quite lovely,
it's
yet
compelling,
we're not seeing
it's infrequent. It's a rarity. Still 95% of coronary bypass first-time cases performed in the United States of America receive a single arterial graft in the rest veins. We have flipped that ratio in my faculty. The default is all arterial grafting unless we can't. And there are a variety of reasons why you can't, and there are a few reasons why you shouldn't, but the default operation is an all-arterial bypass. And I think that if we, just as so much effort and progress has been made in improving medical management and percutaneous management, I think it's time that we improve surgical management too, because that's really our job, to work together to improve the whole field. And to be perfectly honest, surgeons are responsive to supply and demand like every other part of an industry. If you receive your patient back from the operating room and they only got a single arterial graft, ask the surgeon why.
I love that. And the hybrid revascularization, you had this wonderful trial and it stopped enrolling. I'm sure you're frustrated about that, but do vent.
We were frustrated. I won't display the dirty laundry of the NIH in public, but It was that we were in a catch-22 that related to a policy of having a 7-year timeline for funding. If the ramp-up took 2 years and follow-up was to be 5 years, and we had to enroll 2,000 patients, well, do the math. It would require magic to meet the milestones. When we didn't meet the milestones, funding was withdrawn. There are lots of reasons and explanations, but that I think is the bottom line.
Thank you for including me in this panel with so many fine colleagues and experts in this area. I think Roxana, to answer your question, the general cardiologist is looking forward to this new guideline, and especially in recognition of the fact that in the revascularization space, we have the benefit of large randomized controlled trials, as a consequence of which the evidence base is a bit more rigorous than it is in other areas of cardiovascular medicine and surgery. Number two, there have been fantastic advances in both percutaneous and surgical techniques over the course of the past 5 to 10 years that will undoubtedly influence practice. Thirdly, we have increasing improvements in patient selection and post-procedural care that should extend the benefit of these revascularization procedures over a longer period of time. I would echo Dr. Puskas' remarks about the central role of the multidisciplinary heart team, but I would acknowledge the fact that it does not occur as often in practice as has been recommended for now many years. And we need to do a better job in patients with complex coronary disease because of the several options that are available to them. And I think transparency is the currency of the realm. It behooves all of us to maintain a great degree of objectivity when counseling our patients about the choices that they have. And I'm receiving an echo. I don't know if you are, but
no, we're hearing you. We're hearing you loud and clear, and your message is absolutely clear that there's a lot of evidence coming forth that so much improvement has been observed over the last decade, both in medical management, in revascularization strategies, both on PCI as well as bypass surgery, and the fact that we now put the patient in the center of how we make decisions, and we work with the patient. And I think those are all really, really welcomed remarks from you as the head of the task force. And we all so look forward to these revascularization guidelines. And obviously, those of us who are co-authors are not able to discuss them, but we all are looking forward, and I know that everyone is looking forward to seeing what they're going to be. There's a lot of hype, and we should have that, and hopefully we will see a lot of the evidence really come forth and help guide decision makings in patients who are being considered for revascularization. I want to thank you, Dr. O'Gara, for your time, for your beautiful lecture, for your commitment to our course. We're really, really proud to have you here each and every year, if we could possibly get that to happen. Thank you so much for being with us from Boston, from the Brigham and Women's Hospital. Thank you so much to our esteemed panel. And I think we're going to move on to the next phase of the program. Thank you again, Dr. O'Gara.
Thank you.